Welcome. Today we're diving into a fascinating and somewhat complex intersection of diseases: infectious endocarditis-associated nephropathy. It's a mouthful, but understanding this condition is crucial for healthcare professionals and those wanting to learn more about the interconnectedness of our body systems. We'll explore how an infection in the heart can significantly impact the kidneys. So, let's begin. Let's talk about the causes. The primary culprit behind infectious endocarditis-associated nephropathy, as the name suggests, is infectious endocarditis. This is an infection of the inner lining of the heart, specifically the heart valves. Bacteria, most commonly Staphylococcus aureus or Streptococcus species, are the main instigators. These bacteria enter the bloodstream, often through intravenous drug use, dental procedures, or indwelling catheters, and then colonize the heart valves, leading to the infection. It's the body's response to this infection and the bacteria themselves that trigger the kidney problems. Now for the pathophysiology. How does this actually damage the kidneys? There are several mechanisms at play. First, immune complexes, formed when antibodies bind to bacterial antigens, can deposit in the glomeruli, the filtering units of the kidneys. This deposition leads to inflammation and damage, a condition known as glomerulonephritis. Secondly, direct injury to the kidneys can occur due to septic emboli. These are small clumps of bacteria and debris that break off from the infected heart valve and travel through the bloodstream, lodging in the small blood vessels of the kidneys, causing localized damage and infarction. Furthermore, medications used to treat endocarditis, like aminoglycosides, can be nephrotoxic, directly harming kidney cells. Finally, hemodynamic changes related to the heart infection and inflammation can lead to reduced blood flow to the kidneys, further compromising their function. Let's look at the epidemiology, or who is most affected. Individuals at higher risk for infectious endocarditis, and therefore this associated nephropathy, include those with pre-existing heart valve conditions, such as rheumatic heart disease or prosthetic valves. Intravenous drug users are also at significantly increased risk due to the introduction of bacteria directly into the bloodstream. People with indwelling catheters, those undergoing invasive dental procedures, and individuals' weakened immune systems are also more susceptible. While the exact prevalence of infectious endocarditis-associated nephropathy is not well defined, it's estimated that a significant proportion of patients with infectious endocarditis will experience some degree of kidney involvement. What are the signs and symptoms? The symptoms can be a mix of those related to the heart infection and those related to kidney dysfunction. Symptoms of endocarditis include fever, fatigue, night sweats, heart murmurs, and small spots under the fingernails or on the whites of the eyes, called splinter hemorrhages or Roth spots. Kidney-related symptoms may include edema or swelling, particularly in the legs and ankles, hematuria or blood in the urine, proteinuria or protein in the urine, causing foamy urine, hypertension, or high blood pressure, and decreased urine output. In severe cases, patients may experience symptoms of kidney failure, such as confusion, nausea, and shortness of breath. How is infectious endocarditis-associated nephropathy diagnosed? The diagnostic process involves several steps. First, blood cultures are crucial to identify the causative bacteria of the endocarditis. An echocardiogram, either transthoracic or transesophageal, is used to visualize the heart valves and detect vegetations, which are clumps of bacteria and debris. Urine analysis will reveal the presence of protein in blood. Kidney function tests, such as serum creatinine and BNSA blood urea nitrogen, will assess the level of kidney impairment. In some cases, a kidney biopsy may be necessary to confirm the diagnosis of glomerulonephritis and determine the specific type of kidney damage. While infectious endocarditis-associated nephropathy doesn't have a strict classification system like some other kidney diseases, it's important to recognize that the specific type and severity of kidney involvement can vary. The degree of glomerulonephritis, the extent of septic emboli, and the presence of acute kidney injury all contribute to the overall picture. Some patients may experience mild proteinuria with minimal kidney dysfunction, while others may develop rapidly progressive glomerulonephritis leading to end-stage renal disease. Identifying the specific underlying pathological process is important for guiding treatment. Treatment and management of infectious endocarditis-associated nephropathy focuses on two main goals: treating the underlying endocarditis and managing the kidney complications. Antibiotics are the cornerstone of treatment for the heart infection, typically administered intravenously for several weeks. In some cases, surgery to replace or repair damaged heart valves may be necessary. For the kidney involvement, treatment may include medications to control blood pressure, diuretics to reduce swelling, and in severe cases, dialysis to remove waste products from the blood when the kidneys are failing. Immunosuppressive therapy may be considered if glomerulonephritis is severe. Careful monitoring of kidney function is essential throughout the treatment process. Prevention is key. Preventing infectious endocarditis is the best way to prevent the associated nephropathy. This includes practicing good oral hygiene to reduce the risk of bacteremia, avoiding intravenous drug use, using aseptic techniques when inserting catheters, and administering prophylactic antibiotics to high-risk individuals before certain dental or surgical procedures. Early diagnosis and treatment of endocarditis are crucial to minimize the risk of kidney complications. Finally, let's talk about prognosis and recent advances. The prognosis of infectious endocarditis-associated nephropathy depends on several factors, including the severity of the endocarditis, the extent of kidney damage, and the overall health of the patient. Early diagnosis and prompt treatment can improve outcomes. However, some patients may develop chronic kidney disease or even require long-term dialysis. Recent research is focusing on developing more targeted therapies to reduce kidney inflammation and damage. Studies are also investigating the use of novel biomarkers to detect kidney injury earlier and more accurately. Continued research is essential to improve the prognosis for patients with this complex condition.